All right, guys, it's just after 4, so why don't we get started? I see that people are still joining us, but we can go ahead and start presenting some of those cases. This is Jacob Kirsch, current president of NASCI. Um, Greetings to all of you from really wet Florida. It's been raining for a week now, pretty much nonstop. Um, kind of started our hurricane season yesterday. See how it goes this year around. I see we have a bunch of friends from NASCI here already online. Everybody's muted, but why don't we do something different this time? I do have a few cases prepared. If we need more cases, we still have some from Dr. Limanovich that she had shared with us last time that we didn't get a chance to go through. So we can go through some of those that she had shared in the past. But if anybody of the attendees wants to share a case, why don't we start with you guys this time around? Just go ahead and mute yourself, and I'll give you control of the presentation so you can share your cases.
Is that an open invitation, Jacobo, or I missed it?
Yes, it's an open invitation. Are you ready? I can make you present it, Greg.
Sure.
All right. Let's see. So Dr. Kishka is going to start.
Okay.
See.
Let me see.
You should be getting an invite to present. Make presenter. Okay. There you go.
All right. Okay. All right. I just got one cute case here that I just wanted to share with people because I thought it was kind of interesting. This is a radiograph that, or actually rather, this radiograph on the right is a radiograph that we did on a patient a short while ago, and we were shocked when we looked at this. How do I minimize this? When we looked at this contour along the heart border, and particularly became alarmed when we compared it to the prior radiograph, which was a few years earlier. I can't remember actually what the original indication was, but we proceeded to get a CT on the patient and then later an MR, and this actually ended up being a true aneurysm. You know, this is kind of a case that a lot of people have seen before or are quite exposed to, but I just thought it was a great example of how you have this, you know, thinning and bulging of the myocardium at the site of an infarct. You've got this enhanced area of myocardium that's abnormally thin, and adjacent to it, you have a thrombus. This was dyskinetic portion of the myocardium here. The reason I wanted to point this out, one of the reasons I thought this was interesting is because I know, at least with residents who rotate through the cardiac service, and I know everyone is sort of beyond this level of training, the mistake they make is that they will actually go and draw an ROI. Let me see if I can pull up an ROI tool. They'll draw an ROI on something that looks like a thrombus and immediately see, or at least visually inspect it, and say that it has high signal intensity, and they become alarmed that it is maybe not a thrombus. But if you look closely here, you'll see all this etching that is located around this thrombus. And so you know that this actually is being caused by a magnitude image. If you come over here, this is a 3D PSIR that we did, and this one will actually provide us with a phase preserved image as well. Again, this is that same thing. It has to do with this is a magnitude image. There's etching around it. The thrombus is bright, and people will get confused by it because everything about this looks like slam dunk thrombus. If you come over to the non-magnitude image, you can see that the thrombus is in fact dark. So in this image here, the signal intensity is not a direct measurement, but is linearly correlated. Well, is correlated with the amount of gadolinium present in the voxel being imaged. So there's no gadolinium uptake whatsoever in the thrombus. The myocardium has some, and of course the blood pool has the most. But you compare that to the magnitude image, and if you have a scanner model that only provides that, there can sometimes be a moment of confusion when people see those images.
Very cool.
That's it.
Very cool. No, thanks for sharing. Very cool. I think I just a couple of weeks ago I tweeted this case that was slightly similar on the X-rays. It just had it was a chronic infarct. So you had already calcifications in the periphery that you could actually see on the chest X-ray was also a nice clue. But thank you so much for sharing.
And sometimes people get very confused. One of the things that can help people if they're looking at a magnitude image is if you look at the fluid in the stomach, you'll also see that that is bright. And of course, it shouldn't be because of the T1 times of fluid in the stomach are long, and that this is also etched. And when you come over to the right-hand image, you can see it sort of darkens out. And then if you also come over to the phase-preserved image here, on this one, you'll see stomach fluid is dark as it should be, similar to the thrombus.
Greg, what vendor do you use? Those would not look like Siemens magnitude images and phase images. Is it Siemens?
Yeah, so Siemens will have magnitude and phase preserved. We have a Philips which has that. GE, I believe, only has magnitude images. I don't know if there are any GE users out there who can confirm that. And then at some institutions, for whatever reason, their protocols are such that they do not send those phase preserved images, only magnitude images. We had someone who came from an institution who had Philips, and they were throwing away the phase preserved images because they didn't feel they needed them. But I actually think it can be quite, this is not a case where I would necessarily need it because it's such a classic thrombus, but there are cases when you're interrogating a small thrombus, and this is the effect that can cause confusion when trying to decide whether it's a thrombus or not.
Correct. Perfect. Awesome. All right.
Okay.
Much.
All right. I will return screen to you.
Oh, thank you. Thanks for doing that. Any comments? Any questions from anyone out there? All right. Anybody else who would like to share cases? Don't be shy. We're amongst friends.
If no one else does, I have a couple of cases.
Oh.
It's Carol.
Dr. Danny?
It would be nice if someone else has a, yeah.
Yeah, I mean, I think we have time for everyone, so why don't I share the screen with you? I'm gonna make you presenter, and then somebody else is still debating if to present or not. You can think it through and start getting your computer ready for after Dr. Danny presents. Thanks, Carol.
Okay. Okay, you guys can see my screen?
Yes, we can. Thank you.
So this is the first patient. He's 50 years old, and this is also a nice case that I've seen a couple of. I'm sure you guys have seen some too, but what we see on these cine images is a hypointense filling defect in the mid left ventricle. Some mitral regurgitation here, and really globally hypokinetic. On T1, this filling defect is very, very dark, and on T2 spare, also extremely dark. And this is the dynamic perfusion, and you can see that there is no enhancement. And then these are the images. I'm just gonna, part of my screen is masked by the microphone thingy here. So you can see the SAO, the 4-chamber and 2-chamber, that this mass, it kind of looks like it's enhancing in the periphery, but it's probably just trapped gadolinium within the crevices of this very hypointense, non-enhancing mass. So anybody want to hazard a guess as to what this could be? Okay, well, maybe if I show the next study, then it'll become clearer. So the patient also had a cardiac CT, and of course I don't want you to focus on the coronaries, and I want you to focus on this heavily calcified mid-ventricular mass that is tethering the papillary muscles. So does anyone want to hazard a guess now? So this is a calcified amorphous tumor of the heart. It's a rare benign intracavitary mass composed of nodular calcium deposits within fibrinous material. It's quite rare. I've seen a couple, and the most common locations are in the left ventricle and the mitral valve. And the thing is, it may present with systemic embolization. It's often associated with valvular heart disease, mitral annular calcification, diabetes, and end-stage renal disease. So kind of a disturbed calcium phosphate balance. And because of the risk of systemic embolization, the treatment is surgical. And so this patient did have resection of this calcified amorphous tumor, or CAT, of the heart. Okay, any questions about that one?
No, that was great. I've never seen one of those, actually. I don't recall.
I've got another one. I couldn't find it, but it was even bigger and had been present for years, and the patient didn't have it resected.
You may have the only case series out
The
there.
next one.
Yeah, I've never seen one.
Oh, really? Cool.
Not knowingly, at least.
So the second one, I think, is also very interesting, recently seen, and this patient is a 53-year-old man with chest pain. And so I've just taken some images from the cardiac CT that he started with. So in the non-contrast, you can see this hypointense, kind of subtle filling defect in the right ventricle. And Hansfield measurement was approximately 8. Post-contrast, you can see this is sitting near the RVOT, attached to the anterior wall of the right ventricle. And then post-contrast is just another, it's kind of bulging on the sagittal reformat. It's bulging the anterior wall of the right ventricle just below the RVOT. And poor man's delayed MR imaging, 2 minutes post-contrast. Here we can see there's really no enhancement of this on the CT. So the patient went on to have an MR, and you can see that this is a very thin-walled and kind of bulging the anterior wall of the right ventricle, and very hyper-intense. And we have T1 weighted imaging, hypointense, T2 spare, slightly hyper, and perfusion, really no enhancement here. And then the other, this is a T1 fat set, 5 to 10 minutes post-GAD, and then the LGE images here showing that this remains very hypo-intense and absolutely no enhancement of the wall or the internal contents of this. So we concluded that, I mean, we have a differential, but we had a favorite, and our favorite diagnosis is an intracardiac bronchogenic cyst, but there is a differential diagnosis for these lesions. Hydatid cyst would be one, and this person did not have, you know, a foreign sounding name, like they came from Greece, or where we find hydatid disease most commonly, no history of travel. So we didn't like that one. Bronchogenic cysts are exceedingly rare in the heart, but have been reported. I found some case reports in the literature. Congenital blood cysts are usually found in infants, and they're usually on the valves. And then about 14% of myxomas are very cystic, although they tend to be a bit more inhomogeneous on T2 weighted imaging, and do have a little bit of enhancement of the wall, even if they are completely cystic. So this is an example of the case report that I found of almost exactly what we are seeing in this particular case. It's in the right ventricular outflow tract. It's a case from 1996. And this is what they found at surgery, and this one was resected. So we don't have path proof in this patient because it was just recent and it hasn't been resected yet, and I'm not sure whether they will resect it. So very rare case of an intracardiac cyst. So that's all I have for today.
Oh, those are great cases.
Comments?
Those are great cases. No, thank you for sharing those. I was thinking of blood cyst when you first showed it, but like you said, those are usually associated with the valves. If any.
Yeah, exactly.
Great.
Yeah.
Carol, thank you so much for sharing those. Anybody else out there who wants to share a case?
Okay.
You guys want me to call you by names and see if anybody has any? If not, I can show a couple. All right, let me show the ones that I have here. They're not as amazing as the ones that we just saw, but hopefully there's some value to them. I put just some notes here to help me walk you through them. So just rather quickly, this is the first case. It's a 55-year-old male, no significant past history, and he presented to the emergency department with severe epigastric pain and tachycardia. Actually, the patient coded in the ER and was resuscitated and intubated, and then taken to the CT scanner when we were able to get some images on him. I think I put these images on Twitter as intro to the webinar just to get some interest. So this sagittal recon of the study done with contrast. I would love to hear some comments. Do we have any trainees online that would like to make some comments about this? I remember I did see a case like this during training, and then of course we were all sharing it and looking at it because you don't get to see these that often. All right, I'm going to show some axial images as well. Well, actually, I'm going to tilt the sagittal. So you see there the contrast is layering in the dependent portion of the heart, SVC, cardiac chambers, and part of the IVC, just kind of layering there. And if we do the proper axials at two levels, mid-heart and towards the IVC, you can see, again, very concentrated iodinated contrast, just kind of layering there. Any comments on this? All right, so I'm assuming at least most of you should know what this is. This is a patient. He coded again in the scanner right before being scanned. So the heart is not moving. There is no real flow of blood. So the contrast is not mixing with the unenhanced blood. It's just layering there because of higher weight and blood flow. It's just kind of creating this hematocrit effect. This is very classic. That means that if you start seeing this in the console in the CT room, you should run into the scanner and start coding the patient. This is just, again, we don't see this very often, and when we see them, we used to share those because these are always interesting. All right, case number 2. This is another young patient who had chemo-induced cardiomyopathy. As a form of treatment, patient underwent heart transplant back in 2014. That was complicated immediately after surgery with a right-sided failure, required some support, and then the patient developed some ectopic atrial tachycardia, and there were attempts at ablation, again, early in the post-op events for this patient. The patient has undergone several cardiac biopsies as part of his follow-up for the transplant. Patient used to live in California, just moved to Florida, and he came to us for clinical follow-up. And patient had, sorry about that, let's see, there you go. You can see here left-sided injection, and you can see the LAD. It's prominent, but it looks pretty healthy. And then we see all of this contrast kind of pulling into the chamber and kind of leaving the chamber here very anteriorly in the heart. And as we all know, one of the most anterior structures are the right ventricular cavity and the RVOT. So that makes us suspicious that that's into the right ventricle RVOT area, where we see all of this pulling and shunting of the left main injection. I think I have another angle here. So again, very similar, just from a different angle in this patient. And we're very little flow going very distal towards the tip of the LAD. So let's look at the patient went for a CTA after this. So let me show you the CTA. All right, this mouse is being very sensitive here for the, there you go. So this was a retrospectively gated acquisition. There's some surgical material, maybe from the surgical procedure back in 14. Again, nice looking vessels. Very interestingly, if you look at the RCA and look at the LAD, there is no real bifurcation of the LAD, but there is an anomalous circumflex coming from the RCA, the right cusp, I'm sorry, that has a retro-aortic course, which is a benign anatomical variation. And as we go, very interestingly here, we start seeing these vessels, squiggly vessels in the septum that are draining into the tip of the right ventricle. So there's a coronary cameral fistula into the right ventricle. So we see some pulling of contrast here in the tip of the chamber of the right ventricle here, whereas there's no contrast pulling before or after it, really, at the time of acquisition. So we have a coronary cameral fistula post biopsy. If you recall, when they do the biopsies, they try to come towards the septal part of the RV. That's where they put their catheter with the biopsy device. So sometimes they can bite into one of the septal perforators. So if they're very aggressive, they can even get a piece of the vessel, especially if you have a very deep vessel that may have some intramyocardial bridging. So this is a very nice case. Let's look at it in the different orientation without getting too fancy. This is a true coronal through the chest, and you can see here where there's a drainage into the trabeculated RV from that coronary. So that's fistulization right there. So again, this does happen. It's a known complication of all of those post-transplant biopsies, and hopefully they never require any therapy other than just continuous follow-up. Any questions about this case?
Yeah, I have a question. Doesn't it act like a sump? Like, do they not get
Some
ischemic? Because it's
it could. This specific case did not, but definitely yes, they can definitely have a still phenomenon. I don't know if this is because it was very distal and we just didn't have any evidence of it. Again, it's a transplant case, so you would expect that heart to have been pretty healthy, meaning there's not a lot of collateral flow yet um, uh, to support that. But you're absolutely right. They can undergo some still phenomenon and ischemia like any other coronary fistula. Which actually is a perfect segue to this case. Thank you for that. So this is a 64-year-old male presented with shortness of breath. Patient had an abnormal nuclear stress test at an outside institution. We don't have access to those images, but according to the report, there was a question of ischemia on the circumflex territory, so lateral wall of the LV. The EF was also on the lower side at 45%. So the patient went for a cath, and this is an injection. This injection on the left circumflex. You can see that's a really sizable circ, pretty big. Doesn't look like have a lot of irregularities, although it is tortuous and large. And then you can see again distally, it seems to be communicating with one of the chambers. You see that pooling of contrast there over the chamber. That seems to be pooling there before being expelled on systole. Let's see. I have another view. Again, just gonna let it run a couple of times so everybody can see it. And another view. This is just to show that the right coronary artery looked pretty good, maybe minimal atherosclerotic disease proximally there. You see a tiny bit of irregularity in the wall. So let's look at the CT. Patient went for a CTA. After this, here we go. I want to make sure I show you the correct examination. I think it's this one. So patient had a preliminary study without, and you can see there's plaque, and you can see there's some plaque, but you can see how big the circumflex tortuous and enlarged it already looks. And this is with contrast. Again, very, very tortuous and engorged circumflex artery. The the LAD looks size-wise looks okay, even though it has a fair amount of plaque. And if we move down towards the base of the heart, remember we talked about that there was a communication. We can see here somewhat clearly that there's a fistula between the distal circumflex and the coronary sinus here. Or right prior to the coronary sinus here on the coronary vein, there is definitely communication there. We have a couple other reconstructions. Let's just see if it's a little bit clearer there as well. So it seems to be pretty complex communication. Let's look at this way. Again, I don't want to waste time doing a lot of NPRs, but these ones that are automatically made can be helpful. Here's a circ coming down, and there's a pretty sizable communication here. and here with the coronary sinus. So let's see. So this patient, actually, they tried to take him to the cath lab for therapy. The idea was to stent the coronary sinus. Since it's bigger, they went retrograde, and the idea was that it was going to be more amenable to being stented with a cover stent. Trying to come integrate from the circumflex, since it was so tortuous, it was thought that it was going to be more difficult. So they started going retrograde into the coronary sinus. Unfortunately, they could not get through and get a wire through and maneuver into it to deploy a stent. So then they went ahead and tried to go integrate via the circumflex, but they were unsuccessful as well. So now they're looking into other options. The patient went for a cardiac MRI. I don't have images for that because it doesn't really show much, but it did show they did a QPQS analysis to see how much was shunting, and the QPQS was only 1.1. So definitely not the clinical reason to perform the procedure. However, the real reason here is that, like Carol asked about the prior case, there was evidence on the nuclear stress test that there was ischemia involving the circumflex territory, the lateral wall of the ventricle. So there's a still phenomenon, and that's sufficient to guide therapy. So this patient may end up having a mini thoracotomy maybe, and ligating that has not been decided. So just very quickly, so coronary artery fistulas, they're rare. 0.1 to 0.2% of all congenital heart defects are very rare. Specifically, those from the circumflex are the most rare of all of those fistulas. Usually are described in adults. I only found one case in a pediatric patient. Seems like this can be indolent for a while for some reason. Those are going to the coronary sinus. So about, just as a quick review, 50% of fistulas come from the right coronary artery, 42% from the left coronary artery, and about 5% you have multiple fistulas from both coronaries. Very rarely do we see circumflex artery fistulas like the one that we showed. And again, now based not of origin, but by drainage, this fistulas usually run into the right-sided chambers, the ventricle, atrium, and pulmonary artery. That's kind of makes sense, right? Because 50% are on the right coronary artery. So they're going to be more common going to the structures adjacent to it, and just a small amount to the coronary sinus. So it's really one of the rarest coronaries to fistulize, and to one of the more rare also destinations, the coronary sinus. So this pretty rare case that we just saw. The fistulas, as we commented, they can lead to still phenomena. So the blood goes from the high pressure to the environment of the myocardium to a low pressure chamber. So we're going to be shunting blood in that direction. And again, as there's a decrease in this pressure, the heart will start to create this ectasia or dilate this coronary to try to increase flow, and it can also lead to aneurysm formation and at some point thrombosis. So the sequelas can be not immediate but long term. So these patients definitely require continuous follow-up. Clinical presentation, mainly on the size of the fistula, and if they have these aneurysm formations with thrombosis, etc. And very interesting, sometimes these coronary fistulas, depending on how much they're shunting, patients can present with high cardiac output congestive heart failure. And again, treatment nowadays, usually transcatheter is the go-to guy, but they can have just a follow-up if there's no evidence of sequela, or if needed, surgical closure. Again, all based on the clinical condition of the patient. This is my last case. I would take comments from all of you because there's still to be known about this patient. This is a very young patient, 39-year-old male, abnormal echo. They've actually known about this. The patient has a history of hypertension and left ventricular hypertrophy. The hypertension, according to the clinical notes, started when the patient was 13 years of age, so started at a very young age. Probably have, well, not probably, but most likely has some sort of congenital abnormality of some sort, some systemic disease that has not been fully elucidated till date. And then he came to us for some therapy. He was told that he had an abnormality in echo, and he was mentioned that he should only need serial echoes for follow-up in the past. Let's look at the CT. Even though I kind of showed you the answer, I guess, but doesn't matter. It's still a great image. Without contrast. This is really a great image here. It's a beautiful CTA. And you can see, look at the left main, just pretty engorged LAD, RCA as well, lung segments. So people would call them ectatic. I think we can call them aneurysmal. Usually if they're over 1.5 times the size of the adjacent normal coronary, we start calling them aneurysmal. Between anything between 1 and 1.5, we start using the term ectasia, also depending on the length. I think when they're longer, we tend to call them aneurysmal, and when they're less than a centimeter in length or solitary, we call them ectasia. Regardless, this has involvement of at least 2 of the epicardial coronary vessels. But also what's very interesting in this particular case, because I think most of us have at some point seen an aneurysm or some ectasia, if you look here at the distal right, there seems to be this mural low attenuation, and even here, this mural almost nodular low attenuation here. Let's see what it looks like here on our sagittal recons. When we look under the heart, let me go the other way. I think this is a good view here of this mural low attenuation. So this patient has some mural thrombus involving the distal RCA. You can see maybe a little bit here, definitely some here as well. All the way through. So there's some mural thrombus on this patient, on those ectatic coronary arteries. So coronary ectasia, we kind of talked about them. The treatment is conservative. Actually, this is a slide from the prior one. So anyway, so treatment is conservative, and follow-up on most of these cases. Thrombosis, mural thrombus, has been described. It's not uncommon. Again, it kind of fits Virchow's triad of slow flow. Not only that, there's pro-inflammatory substances that can be secreted by the coronary that's ectatic itself. It has been demonstrated that these coronaries tend to have inflammatory features, so they secrete locally inflammatory markers that can then give rise to a hypercoagulable state locally, and they can thrombose. So some of these patients will be in anticoagulation, either aspirin, for life, or maybe may require something more aggressive. So this patient, we're going to continue to follow up as he progresses on their aspirin. Now, going back, patient very young, hypertensive, and now we have that. Any comments from you guys on what we can be dealing with? I really don't have much history in him. We're just starting the workup. We don't know if we have some systemic collagen vascular disorder, or maybe he had Kawasaki's. And as we know, about 50% of pediatric patients with Kawasaki, the aneurysms or ectasia regress. The other half, they don't. This may be very well one of those cases where this persisted. The patient does have an interesting name that it's definitely foreign to the country. I don't know exactly what nationality, but it definitely sounds potentially African or so. Does not sound Southeast Asian, which again would be a clue into Kawasaki, I guess, but nevertheless. So any comments or questions, anything that you guys think may be interesting to add to this case? All right, great. Anybody else has a case they want to share?
Jacobo, I can show a companion case to the first case you showed.
Fantastic. Let me make you presenter. That is great. Thanks, Carol. Let's see. All right, you should be able to take over now.
Yeah.
Perfect.
So this is a 43-year-old with exertional chest pain. And I don't have as much history as you did for your cases, but this was the cardiac CT. So you can see in the coming up here in the soon to be left AV groove, very dilated left main coronary artery. And we saw the LAD go down, and it's normal in size. The right coronary is normal, so there's a very dilated left circumflex coronary artery. And continuing on, maybe I'll speed it up a little bit here. You can follow that down. And you can see a very dilated coronary sinus and a branch here of the left circumflex. And I'll just show a still image, I think, because it's very difficult to perceive where that fistula, I think you can see it coming here, right here, into the coronary sinus. So for this extremely rare example that Jacobo had, I also have an example. And this patient, so here we see the fistula. So this patient, they were able to percutaneously plug that fistula, and he did have some ischemia on nuclear medicine stress examination, and so a nice companion case.
It's great. It's nicer than mine, but we have a series now. You want to publish it?
Yeah, we could.
Perfect. Thank you.
I'll give you my two cats too, my amorphous tumors.
Jacobo, this is Juan. I can show a companion case also,
Oh, fantastic. Let me,
if I can.
Great.
yeah, of course. Let me see if I can, let me see if I can get you on. 1 second. Let me get the list of people here. And Dr. Battle, you are on. Thank you. Thanks, Carol.
Okay, can you guys see? Okay, so this is a companion to Dr. Denny's case from earlier today. Here we have SSFP, and then we see the mitral apparatus is very abnormal. There's mitral regurgitation, which is what led, this was a 67-year-old male, and the main abnormality was mitral regurgitation on echo. Nothing else was mentioned on echo, actually. We found this with this complex kind of wad-like mass at the mitral valve apparatus, and very low signal on MRI, which we suspected was calcium. And so if we want to get a better look at that, we can see how I switch screens here. How do I switch the screen? Share something else. All right, share. Now, can you folks see the CT?
Not yet.
Hold on. Just waiting for people to see screen. Not sure why that's not showing.
You want me to share with you again? Take over and reshare with you?
No, it's just it says it's waiting. Hold on one second. Let me change it. It says people can see your screen. Are you able to see?
We're still looking at the MRI screen. Let's do this. Let me take over and share with you again so you can choose which screen you want to.
Yeah, let me just do that.
I'm going to make you presenter again, and you can choose the appropriate screen.
Yeah.
There you go. That should do it.
Yeah, it's doing the same thing. I was able to press stop sharing and then restart, but for some reason it says it's sharing the correct screen. It's just not showing.
Okay.
That's a shame.
Well,
All right. Well, in any case, it was very similar to the case Dr. Denny showed, where there's this kind of complex amorphous mass at the mitral apparatus. It bridged actually both the anterior and posterior leaflets of the mitral valve, causing kind of what they thought was almost like a parachute valve-like abnormality, and extended to have amorphous tissue all the way up onto the valve leaflet. So creating that mitral regurgitation, and we'll probably end up needing to go to surgery to evaluate that and potentially resect. So interesting cases.
Yeah, perfect. Thank you, man. All right, I got a note from Dr. Morris down in Arizona. So Mike wants to share a case. Let me make him presenter. All right, Mike, you should be able to share your screen.
Okay, can you see my screen?
Yes, it's on the small side for some reason, but yeah.
Small side. Okay, let me see if I can fix that. 1 second.
Because your monitor is vertical. That's why. That's okay.
Yeah. Let me fix this. So here I can show it this way. Can you remake me the presenter, and I'm using a different script monitor now.
I can try.
Did that work?
Almost. All right. You should be getting the prompt now.
All right.
There you go.
Do you see? Is that better?
Yeah, definitely. Thank you.
Okay. So these are a couple of. So first of all, good afternoon, excuse me, to everyone. Jacob has rain. I read about that once in a book, but in Arizona we don't see that very much. So, but we do have a lot of swimming pools. All right, so these are a couple of structural cases that just came across actually in the last couple of weeks. So I thought I'd show. So this is a 64-year-old gentleman who has severe AS and had. So this is the so he was referred for a TAVR, and this is his pre-procedural CT, and you can see he's got quite severe calcification both on the valve and then even the subannular area, and so. To minimize the chance of a root rupture, they put in a core valve. And during the core valve, they had some trouble getting it seated properly, and they actually had to do a couple of balloon post-dilatations. And the patient did well for a couple months and then subsequently came back with progressive shortness of breath. And so they did an echo, and this is the echo wasn't great quality. This was all done on the outside, and you can see there's a little bit of PVL. See this blue jet here. So this is a peristernal long axis view, so equivalent to a 3-chamber view. There's some LVH. And they thought, well, maybe the patient's symptoms are due to PVL. And so they brought the patient to cath to potentially put in a plug. And this is the image from the cath. And you can see here there's pretty extensive calcification at the annulus, which we know about. The PVL is really hard to see, but if you look here, there's a blush of contrast that shows up over here. See that? So, and this, by the way, just to orient you a little bit here, you can see that the shadow here, the left coronary, and here's the RCA. So this contrast is heading out towards the right-sided chambers. So then they stopped, and then they did a repeat echo. And here's the repeat echo, and this is a short axis view, and here's the valve. These are transthoracic images. And I don't know if you can tell, but there's a blush of contrast here going anteriorly on the short axis view. So any thoughts as to what that could be? So the concern was that there, I'm sorry, go ahead.
Is it a paravalvular leak?
Yes, so paravalvular leak was known, and that's not really shown well on this view. And unfortunately, so I only have, first of all, I only have the 2D echo images. They didn't do a 3D echo, which would have been great. And there is that paravalvular leak, absolutely. And there's this contrast jet going anteriorly. So the paravalvular leak we saw before was going sort of in the plane of the sort of down through this, through the TAVR valve. But the question was, what is this? And this is a form of a paravalvular leak, absolutely. But they weren't sure, and so they brought the patient to CT. Actually, they did an MR. This was done on the outside of the MR, and it unfortunately was non-diagnostic. And so they brought the patient for a CT scan. And here's now a cone-down view, short axis, if you will, on the valve. And I'm going to slow it down and just going through. So here's the core valve, and we're coming through. So now we're above the valve, above the leaflets, and now you can see the leaflets. Oops. Well, there you go. Now you can see the leaflets coming through here. And this image is corresponding to what you saw on the echo. So remember, there's this blush of contrast going anteriorly. And here's the, so here's corresponding still images. And you can see that actually there's a communication between the region of the non-coronary cusp and the RVOT. And if you squint carefully, you can actually see there's and I apologize if it's not showing well, but actually there's a slight difference in the Hounsfield unit attenuation in this region because there's a jet of contrast that's going anteriorly, which corresponds with the abnormality on the echo. So this is actually a VSD between the aorta and the RVOT. But as you recall, and as was just mentioned, there was also this question of a PVL, and so this patient has both. So this is really a contained rupture of the annulus with the subsequent development of a VSD anteriorly, and then there's this. Here's the VSD, and then here's the PVL. So this is not common, but of course has been reported. And here's just an article that talks about this. And the most commonly associated risk factors for this is basically patients who get either a balloon expanding valve or have balloon post-dilatation or even maybe a BAV before their TAVR. So this patient is, like I said, this just came across actually last week, and so they're going to attempt to plug this VSD, and most patients, assuming they survive, do okay with the VSD plug. And then they're going to, as a staged, see if the patient gets better, and if not, then they'll plug the PVL.
Mike,
any comments?
The images on the cath, the theta extravasation of the contrast, it seemed like it was really stagnating and pulling there. You would expect it to really be moving away pretty quickly.
See how it's pushing out that way? You see that? See the jet right there?
Yeah, I guess you're right, yeah.
So it's definitely going into the chamber. And it's, the question is the VSD the cause of the symptoms, the PVL the cause of the symptoms, or probably it's just the combination of both. But, most of us, having done this now for many years, have seen a fair number of these procedures, but usually it's rare that we'll see, first of all, a VSD and second of all, a CT of a VSD post-TAVR. So I just thought it was worth showing. It's not a common complication, but it is known, and most commonly these are just imaged with echo and we never see them. So the second one, just for the sake of time, I'll be very brief. This is a patient who had one of the earlier core valves back in 2014, and then came in just in the past couple months with progressive heart failure symptoms. They did an echo in the office, and as you can see, he had recurrent severe AS across the prosthetic valve. And so in these situations, either they'll do a 3D echo or a CT scan oftentimes just to make sure there's no leaflet thickening or thrombosis that's causing the recurrent symptoms, assuming everything else looks okay, especially because sometimes it can be hard to see the prosthetic leaflets through the frame, notably with the core valve because of the length of the valve. So this patient was brought to CT to look for evidence of thrombosis or leaflet thickening as a cause of his AS. And here's just a single view, and you can see here's the core valve. And on the Cine view, and I'm sure it's not showing up wonderful on your images, but here you can see there's one leaflet here that seems to be moving fine, but the significant finding here is this opposing leaflet, which is the non-coronary cusp, which is calcified and has restricted motility. And so this is early degeneration of a structural heart valve. We've seen these with bioprosthetic valves, and now we're starting to see these with TAVR valves. Now we've been doing them clinically for enough years. So most of the time we're tuned in to look for leaflet thrombosis or thickening as a cause of symptoms, but in this case it's just structural degeneration. And there was a nice article in Circulation a couple of years back by Dr. DeVere's group and the group up in Vancouver outlining this, and this is just a pathologic example of calcification, degeneration, different types of early degeneration of prosthetic leaflets. So that was it, just two recent cases.
Perfect. That's awesome cases, Mike. Guys, it's 5 o'clock. I know that there's other people that want to share cases. I would, if you guys don't mind, we'll take a rain check. Talking about rain in Florida, and I promise you guys we'll go first next month, first Tuesday of July. I'll make sure to send out the notes in advance, make sure that everybody's here. Thank you everyone for sharing your cases. I mean, we had a fantastic, really great cases today, and a really nice show from everyone. So that was really great. I appreciate it. Thank you so much for everything you guys do. Please stay safe out there. Take care, and we'll see you hopefully very soon. Thank you, guys.
Thanks, Jacobo.
Thank you.